video is about the therapeutic uses of corticosteroids. In my earlier lectures, we have learned how corticosteroids are useful as replacement therapy in the management of adrenocortical insufficiency, both acute and chronic adrenocortical insufficiency, congenital adrenal hyperplasia. So these drugs are useful as replacement therapy in adrenocortical insufficiency where the hypothalamic pituitary axis gets involved. Glucocorticoids have important uses in diseases that do not affect the hypothalamic pituitary axis, and they are known as non-endocrine uses of glucocorticoids. So today in this lecture we are going to focus our talk on non-endocrine uses of glucocorticoids, where glucocorticoids are used in a variety of rheumatic disorders. Two of the important actions of glucocorticoids are anti-inflammatory and immunosuppressive effects, and because of these properties, glucocorticoids finds its use in the treatment of chronic inflammatory and autoimmune joint diseases such as rheumatoid arthritis. So rheumatoid arthritis is characterized by pain, swelling in the joints, stiffness in the joints, and over long period, the inflammation associated with rheumatoid arthritis can cause bone erosion and joint deformities. So this can lead to complications in rheumatoid arthritis. So the treatment goal in rheumatoid arthritis is 1. To reduce the symptoms of joint disease such as pain, swelling, stiffness, and 2. To decrease the progression of the disease, to decrease the inflammation mediated damage to the bones and the joints, and thus prevent complications. So the drugs that are preferred in the management of rheumatoid arthritis is disease modifying anti-rheumatic drugs, which is also known as DMARDs, especially methotrexate, which is commonly used in the treatment of rheumatoid arthritis. But the major drawback of disease modifying anti-rheumatic drugs is that these drugs are slow acting. They can take even weeks or months to produce full therapeutic effect. So in this situation, glucocorticoids can be used to provide immediate relief from symptoms of the joint disease when the patient fails to respond to first-line treatments such as physiotherapy or non-steroidal anti-inflammatory drugs. So glucocorticoids act as stabilizing agents and provide relief from symptoms until the disease-modifying anti-rheumatic drugs takes full therapeutic effect. So glucocorticoids act as stabilizing agents. They reduce the progression of the disease, help to bridge the time between the initiation of therapy and the clinical response to disease-modifying anti-rheumatic drugs. Glucocorticoids are also useful in the management of serious inflammatory and vasculitic disorders such as SLE, that is systemic lupus erythematosus, and other vascular diseases such as polyarthritis nodosa, Welchner's granulomatosis, Church-Strauss syndrome, giant cell arthritis. Glucocorticoids are also of benefit in the treatment of non-inflammatory degenerative joint diseases such as osteoarthritis. They can also be used to treat regional pain syndromes such as tendonitis, bursitis, and here glucocorticoids can be used as local injections to reduce the episodic disease flare-up. But to be kept in mind that repeated intra-articular injections can increase the incidence of painless joint destruction. Therefore, it is recommended that the intra-articular injections be performed with an interval of at least 3 months to minimize the risk of complications. Next is the use of steroids in renal diseases. Corticosteroid is the primary therapy in the treatment of nephrotic syndrome secondary to minimal change disease. Minimal change disease is a kidney disorder which is characterized by increased permeability of the renal membrane and loss of proteins due to damage to the glomerular filtration barrier. Most of the patients with minimal change disease respond well to steroids. 95% of the patients undergo remission within the first 3 months. However, with the cessation of steroid therapy, the patients may relapse, the disease may relapse, and patients who relapse repeatedly with steroid therapy are termed as steroid resistant. So patients who are resistant to steroid therapy are treated with immunosuppressive drugs such as cyclophosphamide, azathioprine, and these patients are known as steroid resistant and they are treated with immunosuppressive drugs. Next, what is the role of corticosteroids in allergic diseases? Glucocorticoids have a limited role in severe allergic reactions such as anaphylactic shock. So let's see why glucocorticoid is not preferred in anaphylactic shock and epinephrine is the drug of choice in anaphylactic shock. So anaphylactic shock is triggered by massive release of pro-inflammatory cytokines and mediators from the mast cells and basophils into the blood circulation. So it is characterized by angioedema, bronchospasm, so respiratory distress occurs, there is nausea, vomiting, abdominal pain, there is hypotension, so the blood pressure decreases, there can be circulatory collapse. So anaphylaxis is a life-threatening condition which requires immediate therapy with epinephrine. So how is epinephrine useful in anaphylactic shock? Epinephrine, by stimulating the beta-1 receptors of the heart, increases the contractility, the cardiac output increases, so this restores the blood volume. By stimulating the alpha-1 receptors of the blood vessel, it increases the blood pressure, it raises the blood pressure to normal, and this helps to restore the blood pressure to normal. And also due to action on beta-2 receptors of the bronchial smooth muscles, they cause bronchodilation, and this helps in relieving the respiratory distress. Glucocorticoids, on the other hand, are unlikely to be effective in a life-threatening condition such as anaphylactic shock because they have a slow onset of action. The action is delayed by 4 to 6 hours. It takes 4 to 6 hours to start working. Therefore, it is unlikely to be effective in an emergency situation, in a life-threatening condition like anaphylactic shock, and this is where epinephrine is very effective in maintaining the vitals, in reducing the respiratory distress, and is the drug of choice in anaphylactic shock. But to be noted that glucocorticoids are of benefit in allergic diseases of limited duration. For example, hay fever, serum sickness, contact dermatitis, drug reactions, bee stings. So these are some of the allergic conditions where glucocorticoids are useful and they are appropriate, and in severe cases IV methylprednisolone can be used. In less severe disease, antihistaminics or H1 blockers such as chlorpheniramine, diphenhydramine, promethazine are drugs of first choice in the management of less severe allergic diseases. Next is the use of glucocorticoids in bronchial asthma and other pulmonary conditions. In bronchial asthma, in patients with severe asthmatic attacks requiring hospitalization, high dose of parenteral glucocorticoids are used, and the glucocorticoids that are preferred are hydrocortisone, hemisuccinate and methylprednisolone. In less severe condition, oral steroids can be used, but long-term use of oral steroids can increase the risk of side effects such as hypertension, diabetes mellitus, osteoporosis, psychosis, and other side effects. Therefore, oral steroids have largely been replaced by inhaled steroids. So what are the advantages of inhaled steroids over oral steroids? Inhaled steroids are directly administered or delivered to the lungs. They produce local action. They are effective in smaller doses and therefore the side effects are less. The side effects are less, the efficacy is good, and therefore inhaled steroids are preferred over oral steroids in the management of bronchial asthma. But some of the side effects of inhaled steroids are dysphonia and oropharyngeal candidiasis. These side effects occur because of the immunosuppressive property of the inhaled steroid, which gets deposited in the mouth during inhalation. And because of the immunosuppressive property, the local immunity decreases, and this increases the risk of infections such as oropharyngeal candidiasis. So these side effects can be reduced or minimized by using a spacer or rinsing the mouth, which decreases the deposition of drug in the mouth. Also, the use of synthetic steroids such as beclomethasone and cyclizonide are designed to have low oral bioavailability. So these drugs have low oral bioavailability, so the systemic side effects are reduced. Also, these inhaled steroids are activated on reaching the lungs in presence of lung esterases. So even if it gets deposited in the mouth cavity, it does not adversely affect the mouth cavity because it is in the inactive form. It gets activated only when it reaches the lungs. When it comes to other pulmonary conditions, antenatal glucocorticoids such as betamethasone, dexamethasone is administered to women in the setting of premature labor, and this decreases the incidence of respiratory distress syndrome, decreases the risk of intraventricular hemorrhage and death of the infant. So glucocorticoids are administered to women with definitive signs of premature labor between 24 to 36 weeks of pregnancy, and this decreases the risk of complications. Next is glucocorticoids are indicated for the therapy of specific infectious pathogen. Two of such examples are glucocorticoids are of benefit in AIDS patient with mucocystis carini pneumonia, and the second example is they reduce the incidence of neurological impairment that is associated with meningitis caused by H. infancy B in infants and children. So neurological impairment is a complication of meningitis caused by H. infancy B in infants and children, and this can be reduced by the use of glucocorticoids. Now, glucocorticoids are also very useful in the management of ocular diseases and skin diseases. So, I have a detailed video on the use of glucocorticoids in ocular diseases, the use of glucocorticoids in skin diseases, where I have discussed in detail about the indications, precautions, contraindications, side effects. Next, we move on to the use of glucocorticoids in gastrointestinal diseases. So, glucocorticoids are indicated in selected patients with inflammatory bowel disease such as ulcerative colitis and Crohn's disease. So, patients who fail to respond to conservative management such as diet, rest, or sulfasalazine may benefit from glucocorticoids. So, in mild ulcerative colitis, hydrocortisone is used as retention enema. Glucocorticoids are particularly useful in acute exacerbations. In severe acute exacerbations, oral prednisolone 10 to 30 mg per day can be used. And in severely ill patients with fever, anemia, anorexia, nutritional impairment, large doses of oral prednisolone, that is 40 to 60 mg per day, can be used. However, it is to be kept in mind that despite the use of corticosteroids, complications of ulcerative colitis and Crohn's disease may occur. And one of the dangers of corticosteroids is that the corticosteroids may mask the signs and symptoms of these complications such as intestinal perforation and peritonitis, and this can be dangerous. It is to be noted that budesonide, a synthetic glucocorticoid, is useful in the management of ulcerative colitis. It can be used as retention enema in ulcerative colitis, and one of the advantages of budesonide is that it is inactivated by first pass metabolism, so very less drug reaches the systemic circulation, so the systemic side effects of steroids is reduced. Also, budesonide is orally administered in delayed release capsules. So this facilitates the release of the drug in the ileum and the ascending colon, which is the site of pathology, and this helps in treating ulcerative colitis and Crohn's disease. So budesonide, a synthetic glucocorticoid, is highly useful in the treatment of ulcerative colitis and Crohn's disease. Next is the use of glucocorticoids in hepatic diseases. Glucocorticoids are of benefit in liver diseases such as autoimmune hepatitis, where 80% of the patients undergo histological remission. It is to be noted that in the setting of liver disease, prednisolone should be used instead of prednisone. This is because prednisone is an inactive drug and it requires conversion into active form in the liver. And if the liver is not functioning, so the conversion of prednisolone to prednisolone will not happen. Therefore, it is better to administer prednisolone instead of prednisone in liver disease in the setting of severe liver disease. Next is the use of glucocorticoids in malignancies. One of the major actions of glucocorticoids is that they decrease the number and function of immune cells. They have anti-lymphocytic property. They cause apoptosis of the lymphocyte, which is why they are very useful in the treatment of lymphomas, Hodgkin's lymphomas or acute lymphoblastic leukemia. Next is glucocorticoids are useful in the reduction and prevention of cerebral edema that is associated with parasites and cerebral neoplasm. It has been seen that glucocorticoids are indicated in the treatment of idiopathic thrombocytopenic purpura, which is also known as autoimmune thrombocytopenic purpura. This is because the body produces an immune reaction against its own platelets, thus decreasing the number of platelets and increasing the risk of internal bleeding, gum bleeding. So, glucocorticoids reduce the bleeding tendencies in idiopathic thrombocytopenic purpura. Also, glucocorticoids are useful in reducing the risk of hemolysis in autoimmune destruction of erythrocytes. In organ transplantation, glucocorticoids are used in high doses during transplant surgery in conjunction with immunosuppressive agents such as cyclophosphamide and azathioprine. These patients are also kept on a maintenance regimen which includes low doses of steroids.